Good afternoon and welcome to today's webinar titled as Impact of Crisis on Access to Health Services for Women with emphasis of the marginalized groups of women. My name is Jasminka Fričić. I am the Executive Director of the association ESA. This webinar is a part of activities foreseen with the strategic plan of the Community Practitioners on Accountability and Social Action in Health, or COPASAH Europe. And I would like, first of all, to share some brief information of COPASAH as a network. Namely, COPASAH Europe is actually a hub that was established in 2021 and represent a regional sub-network to the global COPASAH network, which I am convinced that you have heard of and you are aware of their activities. The Europe Hub was established by 15 organizations and currently has 19 active members. Financially, the activities of the COPASAH network, as well as the initial stage of establishment of the network, creation of the web platform, organization of the strategic meetings, and preparation of the strategic plan and action plans for this network, was provided by PAI, the Champions of Global Reproductive Rights. Therefore, on behalf of ESA, which has facilitated the process of the establishment of the regional hub of the COPASAH network, and also on behalf of members of this network, we would like to thank the PAI on the support provided in this initial and very important stage for us as a network members. On this webinar, we have a representative of PAI that is participating. So if I'm going to pronounce the name correctly, and there is Adebayo, would like to join us and share some thoughts and views or a few words, then please, you are welcome. I'm so sorry that I have just called upon you, but if you are not willing and you're going later on to participate into the discussion, I may proceed. Bye.
No problem at all. Thank you so much, Jasminka.
Yes.
Good afternoon to everyone, or good afternoon, good evening, and good morning to everyone across the world who have joined in this webinar. Thank you so much, Jasminka, for the introduction. It's truly an honor to be here representing PAI as part of the COPASAH partnership, and great to see everyone involved, and even more excited for what the discussions from this webinar. We are extremely honored to partner with COPASAH, and particularly COPASAH Europe, on this work to be able to enhance the work around social accountability, particularly in these times of the pandemic and the impact that the pandemic has had, so we can highlight the importance of the work that COPASAH does and the importance in reaching the most marginalized in our communities. So we're really grateful for that opportunity and look forward to actively participating in this process. Thank you so much.
Thank you very much. This webinar is organized also in partnership with PHM Europe, or People's Health Movement Europe, which is another network, a very important ally to the COPASAH sub-regional network in promotion and transforming health systems towards the realization of the social justice. So please let me pass the floor to Ms. Anna Vračar, who I think that is already participating and is here on this webinar to share some words with us as well.
Hi, and thanks, Jasminka, and thanks everyone who's joined the webinar. Yes, so as has been said, I'm from the People's Health Movement Europe, and we've been working with ESA for a couple of years now. And ESA's contributions to, the building the health movement in Southeast Europe has been really invaluable, and we have learned a lot. And I think that the topic of today's webinar also gives us a lot in terms of connecting with people from other regions and learning from their experience during the pandemic, but also outside the pandemic. So, and yes, I wouldn't want to make my introduction too long. I'm really happy to be here today and to be able to hear more from the panelists and from the participants. And I do hope that in the future we'll also, be working together on how to improve access to healthcare for women, and also to think of new ways in which this can be fairer and more comprehensive. So yeah, thanks all again.
Thank you very much, Anna. So going back to today's webinar topic, let me just share a few facts with you before our distinguished speaker continue to present what is the situation and provide you with much more substantial input, let's say, on the topic that we are going to speak today. Namely, more people around the world are facing humanitarian crises than ever before. And there is an estimation that 274 million people will need humanitarian aid in 2022. So this year, in accordance to the United Nations Office for Coordination of the Humanitarian Affairs. That means that challenges such as COVID-19 pandemic that we are going to speak about today, but also different types of conflicts, forced displacement, climate change. There are so many factors that actually disproportionately impact the most vulnerable, and those are the women and girls, and especially women and girls that are belonging to the marginalized community. They're also highlighting, but also intensifying the existing gender health inequalities. So there is a data that women and girls around the world, anyway, even in a normal times, without having a crisis, are facing different types of barriers in accessing quality healthcare services. And this is especially true of those who are living in rural areas and low-income areas. And I don't have to emphasize that to you because all of you know that fact. However, the COVID-19 pandemic and other humanitarian crises greatly increased those barriers, as we are all aware. One of the barriers is, of course, scarcity of quality healthcare services. One of the issues, thematic issues, or how should I say, a certain health rights that were affected are not only the basic and access to basic health services to women and girls, but also the sexual and reproductive rights. And there is also proof that maternal deaths are also increased as a result of different types of crises as well. I don't have to mention that beside the health or reviewing or how should I say, assessing the access to right to health cannot go along without taking into consideration other types of issues such as gender-based violence, rights to education, and other types of rights who are also indirectly influencing the access to health services to women and girls. Therefore, having in mind what we have already said, on today's webinar, we are having two panels. On the first panel, we have really distinguished speakers who are going to provide you with a valuable input and describe what is the access to services, to healthcare services to different types of women. And especially those who are belonging to marginalized groups. And this session or this panel will be moderated by my colleague Borian Pavlovsky, whom you know very well. And then on the second panel of this webinar, we are going to move forward into formulating or finding ways how we can improve the access to justice to these women as a result of different types of crises and especially of the COVID, as we are going to talk about today. So I will stop here, and in conclusion of the introductory remarks, I am going to wish you a successful webinar today, and I'm looking forward to greet you once again on the next occasion when ESE and COPASAC Europe will organize another event or another webinar. So thank you very much, and I'm going to pass the floor now to Borian to start with the first panel of this webinar. Thank you.
Thank you very much, Jasminka, Anna, and Adebi, for the excellent introduction to the webinar. Welcome all. As Jasminka already said, I will be moderating the first panel. The first panel discussion has a goal to present how different crisis situation affected the health and access to health services for women, especially marginalized group of women. We will talk about Roma women, rural women, women refugees struck by the war crisis in Ukraine, women drug users, sex workers, and different marginalized groups of women. Namely, although in the history, let me just briefly share a couple of slides. In the history, the world has witnessed many crises. But when the crisis struck us in 2020, the pandemic with the COVID-19, unfortunately, the world seemed unprepared for such a pandemic, such a crisis. We can conclude the states were unprepared, the health systems were unprepared, the people were unprepared for such an crisis situation, such an outbreak which struck us all. In one period, the world halted, but also unfortunately, it seems that the health systems also halted to provide regular health services, and all the resources of the healthcare system were redirected towards the response of the COVID pandemic. What were the results? Around 15 million excess deaths associated with the COVID-19 pandemic in 2020 and 2021. So 15 million people died, not just as a result of the COVID, but also a result of a neglected chronic diseases because of the lack of access to the health care services. Most of the excess deaths are concentrated in Southeast Asia, Europe, and the Americas. Today, we have speakers from Europe and Southeast Asia mainly. Just as an illustration, the number of deaths in Macedonia, how much they increased from 2019 compared to the 2020. We have 5,000 excess deaths, more than 5,000 excess deaths in Macedonia in 2020. And only less than half of them were COVID-19 deaths. So we have 2,800 excess deaths from other causes in 2020 compared just to the 2019, in just 1 year, because of the mainly due to lack of access to healthcare services for chronic or other acute healthcare problems. This is Macedonia is 2 million people. So this is 5,000 people is one small city in Macedonia. It's a really huge loss of deaths and lives. And this is just the general figures. Now let's hear what were the main problems that different women from different marginalized and vulnerable communities faced in this in our European region, more precisely in Southeastern Europe. We have three distinguished speakers today, people who are working directly with the marginalized and vulnerable communities and marginalized and vulnerable women. We have Vesna Shapkovsky from Station LED from Prilep, Macedonia. We have Eugen Gita from Romania. And we have Maria Radovic from Juventus, Montenegro. First of all, I would like to invite Vesna to tell us more about the which barriers in access to healthcare services faced Roma women and women from rural communities in Macedonia. Vesna, please.
Thank you, Borjan, and thank for the organization of this webinar on such an important topic. Can you hear me well? Okay. As we all know, the COVID-19 pandemic brought about a large number of registered infected cases and a high mortality rate. Like never before, it stressed the importance of promoting public health and healthcare, showing that all other measures and policies fail if this area is dysfunctional and not available for all. States have a general obligation to protect their citizens and provide adequate healthcare when required. The pandemic affects the operation of the healthcare sector and the scope and manner in which the citizens receive healthcare services not related to COVID-19, such as diagnostic, analysis, and treatment, but also citizens face problems in providing COVID-19 related healthcare. On the other hand, part of the citizens, especially members of marginalized communities, such as the Roma community, and particularly Roma women, face a series of challenges in exercising their healthcare and other related rights. Consequently, the challenges in the application of COVID-19 preventive measures becomes inevitable, such as to what extent are they adapted to the needs of the community, And what kind of impact did they make for the community to successfully handle the pandemic? The Roma community is one of the most marginalized communities in North Macedonia, as it is in many other countries throughout Europe. It continuously faces numerous challenges such as poverty, housing, exercising the right to education and social protection, but also and above all, the healthcare. The negative impact of social determinants on Roma health had an even greater negative effect on their health during the COVID-19 pandemic. Life in poverty and unfavorable conditions makes it difficult for them to comply with the basic COVID-19 preventive measures, to wash hands regularly, frequently, to buy good and quality protection masks, disinfectants, and so on. Unfavorable housing conditions, where the majority lives in small and improvised houses, makes it impossible for COVID-19 positive patients to adequately self-isolate themselves, thus exposing other household members to an increased risk of infection. These conditions are particularly affecting Roma women, since they're the ones that take care of the rest of the family members, especially children and older family members. Additionally, since the most of the working Roma women prior to the pandemic were engaged in the informal economy, during the restrictive measures, they lost their jobs, leading to significantly worsened economic position and financial dependence. As a consequence of these worsened economic conditions and restrictive measures that limit the movement of people, the domestic violence increased, unfortunately, with most of the cases going by unreported due to the fear of consequences, the women having no option to leave the community and take care of themselves, and the restricted working hours of the social care services. Furthermore, the pandemic affects the operation of the health sector and the scope and manner in which healthcare services not related to COVID-19 diagnostics, referral, and treatment are provided, and also face problems in providing COVID-19 related healthcare services. COVID-19 preventive and protection measures on local level were adopted without sufficient consultation with the Roma community. They were adopted in general for the entire population and were not sufficiently adapted to the specific living conditions of this population. Also, COVID-19 prevention and protection measures adopted on national level had only a partial positive impact in dealing with the disease among the Roma community. Part of the Roma citizens were not able to comply and protect themselves adequately due to the specific conditions in which they live, such as poor infrastructure, inadequate housing, and absence of uninterrupted access to clean water. Significant number of Roma women were not able to receive timely, adequate, and good quality COVID-19 related healthcare services, which means that they faced obstacles in receiving healthcare. These obstacles mainly refer to lack of medicines and medical means, waiting too long for medical checkups and treatment, but also inadequate behavior of medical staff. This was particularly critical for pregnant Roma women living outside of Skopje in smaller towns, as well as for women living in rural areas, since for giving a birth during infection with COVID-19, they were referred to go to the University Clinic for Gynecology in Skopje, which later on created a row of administrative difficulties, since the child would then have to be registered with a place of birth in Skopje. All the documents for the child had to be issued from Skopje. If the child tested positive, the clinic would keep them for a longer period under supervision, but they would not keep the mother in a situation where the mother has no financial means to pay for additional accommodation, and so on. Furthermore, as a result of the situation related to COVID-19 pandemic, many Roma women who needed healthcare services not related to COVID-19 were not able to receive timely, adequate, and quality healthcare, which resulted with health deterioration for some of them. This was particularly noted in the primary gynecological healthcare, where the doctors worked with restricted appointments and in some periods only receiving emergency patients. In this regard, even after a decade of reactions by the citizens and the NGO sector, there is no permanent solution for the issue of lack of primary gynecological health services in Shuto-Rizari, the only Roma municipality in North Macedonia. The women from this municipality are forced to go to another places for gynecological appointments, and often face refusal and discrimination in receiving health services. In a period of restrictive measures, this resulted in many women not being able to go to a gynecologist at all. This is also a problem for many women from remote rural areas that have to travel for more than 60 kilometers for a gynecological checkup, something that was particularly challenging in the period of introduced limitations in movement and curfew. Furthermore, general population from the municipality of Shuto-Rizari faced decrease in the number of general practitioners in the time of pandemic, being forced to wait for hours and sometimes for days for a checkup at the doctor or go to another municipality, which costs more time and money. To conclude, the COVID-19 pandemic seriously affected citizens from marginalized communities, particularly Roma women, as it transformed from a health crisis into an economic and social crisis, thus increasing the severe living conditions of this group. To improve this situation, the relevant local and national stakeholders need to take a systemic approach tailored to the specific needs of these people instead of introducing temporal and populistic solutions with no permanent improvement. Thank you very much.
Thank you very much, Vesna, for this excellent oversight of the situation in North Macedonia. In the period when we seen that the COVID, we are seeing the end of the COVID pandemic, as we think at least. Unfortunately, another crisis break out in Europe. It was the war conflict in Ukraine. So I will now would like to invite Eugen Ghita from Roma Just from Romania to tell us what obstacles were faced by Roma women, and especially the refugees Roma from Ukraine, access to health services. Eugen, please.
Hello, everybody. Thank you for the invitation. I will share my PowerPoint to see here. How is it? 1 minute. I not find it. Sorry. 1 minute. I don't know why. Sorry. So I try again. Sorry, Borian. I don't know why I don't find it. I don't know why.
No problem. Maybe I can try.
Oh. I don't know why. Sorry about that. Maybe you can try to share it. Maybe it's better.
Yeah, just a moment.
Okay, I find it.
Okay, perfect.
Okay, all right. Okay, I find it. Sorry.
No problem. Thank you.
So, like I said for the beginning, I'm Eugen Ghita. I'm the president of Roma Just, Roma Lawyers Association in Romania. We established in 2016, and our goal is strategic litigation when become cases about discrimination, abuses, and other cases against Roma community. We monitoring and defending the human rights. I will not tell you many things about the organization. I will go to the slide which is come about the refugees. We started to monitoring the refugee crisis in 5 checkpoints on the borders, Romania with Ukraine. We have the checkpoint to Isacha, which is in the south. It's Suceava in the north. It's another checkpoint with Moldova in Botoșani, and we have in daily basis monitor human rights monitor in the border there, and we was researching for abuses and discriminated cases. In the beginning, in the first 2 weeks when started the crisis from February to 10 March, we heard about many cases about the Roma refugees. They were not allowed to come in Romania because they didn't have the ID documents. When they was allowed to come in Romania, was checked double than others. And one very important issue was the government was prepared to receive and to bring in so many refugees. And for that, the civil society was coming to help. Until 1st June, the numbers, it's 1,098,000 Ukrainian refugees arriving in Romania, and 1,030,000 was living in Romania, and only 84,000 are in Romania now and asking for the refugee status. And that numbers telling us how Romanian government manage the crisis, because the refugees, when become Roma and Roma women, they understood immediately in 2 days when was discussed with civil society. The Romanian government was not prepared to provide a lot of services to them, even it come about the health services. That was, like I told you, about the identity documents. Another issue was about the emergency system, because the refugees who have problem with the health, they have to go to the hospital, but only in the emergency situations. And from there, the Romanian health system, because it's not so modern to say, they understand very quickly they have to live in another countries, like, I don't know, Germany and other countries from west part of Europe. So the government regulated by Ordinance 20 of March 22, the provision of free medical care of Ukrainian refugees voluntary from NGOs and professional organizations provided care included in transit centers and railway stations, and voluntary translators accompanying the refugees to hospitals to facilitate their understanding with the medical staff. That is only the reports, what we know official, but in practice was not happening like this. We monitoring 2 cases, which was with the health problems. One woman has to be operated, and when we came to the hospital, they tell us they don't have money for that kind of operation. And because of the family, they was about 20 members together, and they have to leave Romania to go to Germany. And another case, we had the kids who have also medical problems, and we found them in the church. Then we accommodated to the church because no one from the border wanted to give them accommodation. Even the official state hotels or other shelters, even the civil society didn't want it, Roma in them houses, because many Romanian citizens, ordinary citizens, receive in them houses a lot of refugees. But when was come about Roma with women and kids, because they was maybe 5 members, 7 members, they didn't want it to took them. And we started with our lawyers to document the case and to litigate it, but was not that possible because the victim was traveling in another country. Now in Romania we have centers and shelters in any region. It's a 5 region in, where it's big centers. The refugees are staying there. And with our monitors, we are going there to solve some problems. So when it comes about Roma women, is the same like woman Romanian, you know, Roma, where the system is not so friendly with them. We had also cases about abusing, and we related to them. And the attitude of authorities was very bad, only because it was confused with Romanian Roma. And then they are not provided for the refugees Roma, what they had the right to receive. So the situation is still going, and very important issue, and with that I will finish, is the identity document. In Romania, you have to have the right documents to receive services. And in Ukraine now they split it, the regions. It's conflict zone and non-conflict zone. And from non-conflict zone, they have to have a biometric passport to come in Romania. And if they don't have, the Romanian authorities send them back or put them, you know, in the centers to wait maybe 2 or 3 months to fix that issue with the ID documents. So the situation is not so good for them, and even the Romanian state with our Roma communities are not so friendly. And what we supported here for years, when it comes about Roma women refugees, is the same attitude and the same services which is provided to them. And we had also examples like Roma NGOs was provided help to them, and we will still going on the border to monitoring that crisis. But I told you we focus it now in the centers, regional centers, where they are waiting for the refugee status. Thank you very much.
Thank you very much, Eugen, for giving us this very important insight on the problems that refugees, especially Roma refugees from Ukraine, are facing when they're fleeing their country to another countries, which problems that they face. For the next, we would like to hear more about what obstacles were facing women from different vulnerable and marginalized groups, including women drug users, sex workers. So I would like to invite Maria Radovic from Juventus Montenegro to present these problems with us. Thank you.
Good afternoon, everybody. First of all, I want to thank you for the opportunity to be part of this event and to say something about the situation in Montenegro when it comes to marginalized women, especially women who use drugs and women who provide sexual services. I want to say first that I work at NGO Juventus, and this is NGO established 25 years ago, and we have a lot of years of experience in providing direct support to people in risk of social exclusion and socially excluded people. And our focus is on providing direct support to people who use drugs, prisoners, former prisoners, LGBTIQ community, and sex workers. I'm coordinator of this department. And I have to say that we are a small country, but we have 1,600 clients each year from these communities, and they can get free consultations with our team of professionals, legal advisors, psychologists, psychiatrists, social workers, community workers, and during the pandemic, we saw that there is a big difference in challenges they face with, especially when we are talking about women, our female clients. Most common challenges, first of all, were loss of jobs. They couldn't maintain their economic independence. That led to a risk of social exclusion and a risk of homelessness. And definitely that led to deterioration of their access to healthcare services. And during the pandemic, many NGOs closed their offices and their support services. Our drop-in center for people who use drugs remain open, but under some changed circumstances because of the lockdown and public health measures in Montenegro. But we saw that our clients, especially female clients with children, and have some problems that are very specific. They don't know how to exercise their rights within the healthcare system. Everything was online. When we saw a situation 2 years ago, at first sight, everything was transparent, but we have clients that don't know how to use smartphones. They don't have smartphones. They don't have laptops. That they maybe don't have water or electricity, and we have a lockdown, totally lockdown in the country. They have to go on street to earn money. They need clients. They need drugs because they have addiction, and that is the situation, and they don't have many services and many NGOs or service providers to come to. The biggest problem was that the government of Montenegro focused on fighting the pandemic, and that was all right. But on the other hand, they didn't take into account so many difficulties when we are talking about marginalized groups, especially when we talk about a woman, because when you talk about women who use drugs and women who are sex workers in Montenegro, when there is no any pandemic or a virus, they don't have a position as men in our country, even though those men are from these communities. For example, if someone is woman and is a victim of domestic violence, we don't have a shelter if it is a woman who uses drugs, because they don't know how to deal with that. They don't have a staff that has skills to provide direct support for women who use drugs and is a victim of domestic violence. So yes, we have many problems still in this area, and I have to say that during the pandemic, for those communities we work with, there is, as I said, lack of transparency, and there was a problem with entering into some treatments, such as a treatment for hepatitis B, hepatitis C, or HIV. Many women who use drugs are women who live with hepatitis C virus. So our clinic for infectious diseases was closed for anyone else besides coronavirus positive people. So We have a problem with that. Only smaller capacities of our healthcare system was available for persons living with these infections. So the whole thing about motivate a person to enter the treatment now worsened because they don't want to enter the healthcare system. They saw that everything was in one moment in a mess. There were crowds in the within the healthcare institutions. They don't know how to make an appointment to the doctor. Everything was online, and the whole campaign about vaccination wasn't provide direct information for marginalized groups of citizens, because that was something new, and many of our clients have low education or don't have education at all, because we have overlapping between the communities. You talked about Roma community. Many of our clients are from Roma community. We have someone who is a woman who uses drugs, but she is a former prisoner. She is from Roma community and she don't have skills to enter the employment area, to get a job, to earn money, and definitely healthcare isn't on her priority list. So we had many problems, and we have still many problems when we are talking about marginalized women in Montenegro. We saw how the situation was bad, because we saw that so many our clients with children don't have basic needs, don't have opportunity to meet their basic needs. They don't have a food. So we provide some budget, and just for 8 weeks we provide them with food packages, and we now saw the opportunity to establish this kind of service, and we have our licensed service within our social and healthcare system, social and child protection system, sorry, that is called community-based service, drop-in, and we on this is a way to provide our clients, especially women with children, to get a free meal every day, to have a place to talk with our professionals, to wash their clothes, dry their clothes. That's something that's basic, but they don't have that many of them. I have some numbers that during the 2020, 40% of our clients who use drugs were women, and all of the sex workers are female sex workers. And we have now in last year, 2021, the number was even higher. We have more than 40% of people who use drugs that are female. So definitely we have so many challenges they face with, and I have to mention that one big problem in Montenegro that was so highlighted during the pandemic was our problem with our OST program in Montenegro. We conducted the research last year, and we interviewed 300 patients of buprenorphine and methadone program, and staff that work with them, mostly psychiatrists. So we hear that and saw that there were so many problems during the pandemic. They were given therapies for 7 days, And if police stop them, this therapy is often taken from them, and then they don't have therapy for 7 days. Nobody is going to give it all over again for them for that 7 days. So they have just need to go to a black market that was higher than ever during the pandemic, where they can just sell or buy buprenorphine or methadone. That's something that really is a practice, and we hear that. We conduct researches on this topic, and we saw that providing direct support to these clients. So at the end, I just want to say that a lot of energy was focused on fighting the pandemic, and everything was about coronavirus, but the government of Montenegro didn't been so open about the needs of marginalized people, both men and women. So now we have to have services to provide them with food, to provide them with free showering, to provide them with going with them to the doctor, so they can exercise their healthcare rights. So this topic is very important, and I'm glad I'm part of it in front of Juventus. And I think that just with transparency, with communication, cooperation, we can have some strategies, because maybe this wasn't one-time event and one pandemic. So maybe they told us maybe next wave is going to come. So I think we have to be prepared. So thank you. I will talk to you more in discussion later.
Thank you very much, Maria. So for everyone else who would like to have questions or comments, you can do it after the second panel discussion, or just drop your question in the chat box. Thank you very much for the three of you. Just as a key takeaways, at least for me, from this discussion, is that the pre-existing social determinants of health only aggravated the health and access to healthcare services for the marginalized women, including poverty, poor housing condition, lack of access to water and sanitation, lack of education, and so on. But also, the pandemic brought new barriers in access, because, as you said, the measures imposed from the government brought new barriers in access to healthcare services. Introducing the electronic services is one barrier, inability to work and earn money, and so on. And what emerged from all three of you, the intersectionality was really emphasized during the pandemic. Being a woman, being a Roma, being a drug user, poor, a refugee, everything just aggravated the access to healthcare services and health of this marginalized group of women, because, again, of the already pre-existing conditions of exclusion, discrimination, and prejudice. Thank you very much, and I would like to invite my colleague Darko to move on with the second panel.
Thank you, Borjan. Thank you all. Before introducing the panelists in the second session of the webinar, I would like to emphasize some key points from the previous discussions, and also to add something which will be an introduction to the next session. Women play a critical role in driving economic development throughout the world, and women in poor countries are more likely than men to spend their income on food, education, healthcare for their children. In regards to creating powerful, positive, and measurable benefits to society, despite the important role women play in driving development, women living in poor countries are likely to bear an unequal burden in an economic crisis. And what is very important, based on the statistics, women make up a majority of world's poor. Despite the significant achievements in female or women empowerment, women are often victims of health crises, violent conflicts, and economic crises. Studies shows that 50% of refugees are women and girls are 2.5 times more likely to be out of school in conflict affected areas, and also 60% of maternal mortality deaths take place during violent conflicts, displacement, and natural disasters. More recently, the COVID pandemic brought a public health and also economic crisis that has magnified gender-based disparities, causing decrease in access to healthcare services, reduced economic opportunities, and increased vulnerability to gender-based violence. As the pandemic has disrupted health systems, women are reporting decreased access to healthcare services, in particular services to meet sexual and reproductive health needs. Over 1/3 of women from the Rapid Gender Assessment Survey disclosed that they had trouble accessing medical care during the COVID pandemic. Reducing access to reproductive services correlates with increased unwanted pregnancy and sexual transmitted infections. The Population Fund reports that there were 1.4 million unintended pregnancies as a result of disruptions in access to contraceptive services, especially in low and middle income countries during the first year of the pandemic. In order to address the unequal effects of the pandemic and other crises on women and girls, there is a need for multi-level solutions and multi-level actions, including citizens, donors, government, international organizations, and so on. What should be undertaken in order to enable the healthcare systems to provide the needed health services to women, and how the health system should be more responsive to the emerging needs of vulnerable women, and what could we as a group and citizens, civil society organization could do in order to strengthen the vulnerable women, to increase their resilience and to proactively demand their rights in the area of health and other types of rights. On this topic, we have in the second panel 4 practitioners who will try to give their visions and also inspire the discussion further. And I would like to give a great welcome to Renu Khanna, founder and trustee from CSO Sahaj from India, and also a steering committee member of Copasa Global. Thomas De Jong, policy trainee for Roma Health Project from the European Public Health Alliance. Nilanjana Das, research associate from SAMA, and my colleague Borian Pavlovsky, Women Health Program coordinator from ESE. We can start with the presentation, and I will first invite Renu to start.
Thank you very much. Can you see my screen? Are you able to see my screen?
Yes.
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 Okay. Okay. So I am aware that I have 7 minutes. So I have a very brief presentation. And this presentation actually draws from some work that I have done in South Asia in looking at the gender effects of COVID-19 and the state and civil society responses to COVID-19. And also from my association with the Feminist Policy Collective in India. I am one of the steering committee members of the Feminist Policy Collective. We are a national group, small group, and we have been undertaking budget analysis since the last 3 years of the union government. And we have specifically been looking at the responses to the COVID, the COVID packages which Government of India brought out. How gender responsive were they? So my presentation draws from these two sources, as well as from a very recent COPASA South Asia and Sexual and Reproductive Health Hub of COPASA. We held a seminar about a week ago to look at, again, what civil society organizations did in terms of demanding accountability for the COVID situation. So when I was listening to the speakers of the first panel, I was thinking how similar the situation was in India, in Nepal, and Bangladesh. The discrimination that women and marginalized groups faced, the stigma, the lack of access to sexual and reproductive health services, and the effect on livelihoods and food and nutrition and all of that. And that was a context. And within that context, where the most marginalized and the excluded groups were affected the most, the migrant workers you must have seen in our country faced such terrific hardship, and women amongst them, many of them were delivering, were having childbirths on the roads while they were going back across the country to their homes and their villages. So with all of this situation of extreme economic distress and hardship and the effects on food and nutrition, we came up with some overarching recommendations. And the first one was that public spending on health, nutrition, social protection, and violence against women must be increased significantly. My colleagues pointed out that widows and old age pensions, disability and transgender allowances must increase. Survivors of violence should be included as a special category for social protection. Another recommendation was that urban employment should focus on transgender communities. Food security must be ensured for informal sector, daily wage workers, migrants, women-headed households. And another recommendation was the gender-inclusive labor policies and programs are required, not only for women in the formal economy, but also to support informal female workers. Inclusive and gender-responsive crisis preparedness is required. Decision-making, planning, implementation processes must include women leaders, feminist groups, frontline women health workers for planning and implementation of the COVID-19 response. We saw, and as was echoed in the presentations in the first panel, how women were the first responders, and community-based organizations were the first responders in the COVID-19 response. And they must be included formally in formal spaces for crisis preparedness. And not only in planning, but resources must be devolved. Financial resources must be provided in decentralized ways so that these disenfranchised groups are not, using their own resources for providing the COVID response. They are already impoverished and they're contributing their time, and we cannot expect them to contribute material resources. So that is something that should be done. Preparation of health systems. What can the health systems, how can they be prepared? The first thing that we spoke about, that we highlighted, was data systems. One of the speakers in the previous panel spoke about the lack of transparency. And I think that was something that we faced in India too. there was no data was available, disaggregated data was not available. And so disaggregated data is required. And Borean spoke about intersectionality. And so when we're talking about disaggregated data, we're not just talking about sex disaggregation, but we are also talking about social groups disaggregation. Routine health information systems must be strengthened, and not just the information system, but also how to use that data, how to analyze and interpret that data and use it for planning the disaster response, both at the national and subnational levels. Intersectionality I've already spoken about, but also a gender-based violence risk and gender analysis is required. Improving access to sexual and reproductive health and essential public health services. Sexual and reproductive health services were not, sort of declared as essential services in the first instance. And so that needs to be done. Continuity of services has to be provided, including emergency contraception, contraceptive services, safe abortion services. One of the statistics in our country was that hospital admissions were due to, many hospital admissions were due to septic abortions, and which was because of unsafe abortions, because safe abortions were not being provided in public sector or even in private sector facilities. The other point that my colleagues have been emphasizing is that home births happened. And so this means that training of midwives and formalizing of this cadre is very urgent. Reproductive health services should not be denied on basis of religion or caste or location, which is what happened during the COVID-19 period. One terrific learning was that the use of technology, mobile phones and WhatsApp messages worked during this period, both to deliver telemedical services and also counseling. Mental health counseling. And mental health became a big issue, and that has to become part of the basic package during disasters, including for adolescent girls and boys. You have also spoken in the first panel about gender-based violence and domestic violence within homes. So training staff, so this has to be prioritized by the health systems. Training of staff to recognize signs of domestic violence, prioritize critical gender-based violence services as essential, including case management, psychosocial support, prioritize resourcing of shelters for domestic abuse victims, and not just them, but also civil society organizations who are responding on the front lines, creating safe areas for women to anonymously report violence, such as grocery shops or pharmacies, publicize information on where gender-based violence survivors can seek help, with special attention given to groups that experience marginalization and discrimination, strengthen community mobilization to connect women and girls with different committees that are committed to work at the grassroots level, support livelihood opportunities for gender-based violence survivors. And one other thing was that women frontline workers, 80% of the health workforce is made up of women. And these women at the bottom of the hierarchy of the health system were the ones who were faced a lot of unsafe working conditions as well as exploitation. And one of our recommendations, and these are considered as honorary contractual workers. They are not full-time staff of the health system. So we are recommending that they must be regularized and receive timely payments. I was also supposed to talk on, so what is the preparation required for women in communities? And many of the recommendations in my presentation are also to strengthen women, the livelihoods aspect that I spoke about. And the recommendations which were being made for the health system are not only for the crisis period. These are overall. The health system as well as other public systems have a very powerful role to play also in promoting changes in gender norms in communities towards more transformative masculinities, for instance. So all of that has to happen in a sustained way. Women's collectives have to be supported, and so allocation of funds has to be made so that those collectives can be supported, because that is where women draw a lot of strength from. Let me stop here because I am conscious that I'm probably overrunning my time. And if there is time in the questions, answers, I will come back then. Thank you very much.
Thank you, Renu. I would just like to point three aspects from your presentation. It was very inspiring with concrete directives of how we can go and move further. The one thing was that you have emphasized during your presentation was think that the crisis put women in a more vulnerable position, no matter of the economic development of the country and also the location of the country, which is no matter if the country is in Europe or Asia or in Americas and so on. This is very good point. The second point is that is the need for gender responsive policies that will be adapted to the crisis situation, and the need for decentralization of funds disbursement and also funds access. And the last point was especially citizens and the grassroots organizations to be empowered and supported to be able to mobilize and prepare to act in normal and also in the time of crisis. Thank you for the whole presentation. We can go with our next panelist, Thomas.
Okay, perfect. Thank you very much, Darko. And thanks also to the COPASA network, obviously, for allowing me to represent the European Public Health Alliance here today. Experience with the pandemic and now with the war in Ukraine, I'm really happy that, this topic of health access of women and women from vulnerable communities receives some attention. So again, thank you very much. So to briefly repeat, I represent the Roma Health Network at the European Public Health Alliance. And I'm addressing quite a difficult question today, namely how health policy and health systems need to be developed in order to see to women's health needs in times of crisis. Now, in my case, I will focus more on Europe, but you will see that I actually have a lot of things to say with what Ms. Khanna said before me. So let me just get started. And before I can address the question, obviously, I think it's important to underline how current health systems fell short on addressing the health needs of women. And that is, even before looking at it from a crisis perspective. For one, the first thing to talk about the fact that data on gender health equalities is lacking. And this makes it very difficult, obviously, to address equal health access. The European Institute for Gender Equality has a gender equality index, and this index shows slight access to care, only 0.5 percentage point. And this may seem negligible at first, but I believe it also shows the complexities of gender inequalities when it comes to health, and that they are not sufficiently monitored in member states for the most part. As Ms. Khanna also said, only through collecting disaggregated data on health on the national level can we foster an evidence-based approach to health policy, because if we don't know the issues, we can't combat them. So that's one issue. A second issue is regarding crises themselves. The COVID-19 pandemic obviously laid bare gaps in health, particularly among people groups, but also on the gender dimension. The same thing, again, can be said for the war in Ukraine. In both cases, unfortunately, women are not an exception. One example I'd like to point out is violence against women. The World Health Organization, for example, reports that 45% of women have experienced or know a woman who experienced domestic violence since the pandemic started. You know, quite a worrying statistic. And a recent UNAIDS report also points out that domestic and sexual violence in Ukraine has increased after the war started. Although unfortunately on this case, there are no statistics available, there's only reports, but that points out the similar issue where there's no data available on this yet. A different issue, but also no less important, is the topic of the care burden, was also already briefly pointed out by Ms. Khanna. The OECD, for example, reports that in OECD countries, 70% of people in healthcare are women. Now, not only does this cause women considerable stress, a large burden on the shoulder of women, but it also exposes them more to viruses, such as in the case of COVID-19, more so than men in that case. And at the same time, women are often not involved in decision-making or policy-making as it relates to the healthcare sector. So even though they are overrepresented in the sector, they actually have less influence in decision-making itself. When I refer back to the same UNAIDS report that I mentioned before, it paints, a similar picture also in Ukraine again. So even before the war started, the vast majority of in Ukraine, 83% were women. So this means, again, in Ukraine as well, they have an increased care burden. And this shows, I think, a large shortcoming that you see all across Europe. Existing health systems, in a sense, put all their eggs in one basket. They place such a large burden on women as opposed to men that it's once a crisis breaks out, it upsets the balance in that. Now, talking about the issues that I've talked about up until now, it's already becoming quite complex, but it becomes even more difficult when we then introduce the topic that was also already mentioned a couple of times today, intersectionality. Something that I partly work on as well as part of the Roma Health Network, of course, are at an even more disadvantaged position simply for the fact that they are Roma. Now, in the European Union, this is addressed through the Roma framework. Member states are required to submit inclusion strategies. But in my analysis of these inclusion strategies, the ones that are available up until now, there's often a lack of plans to improve female healthcare and childcare policies alike. Now, as I'm waiting for some of these strategies even to be submitted, even though we're already way past the deadline. And this coincidentally also counts for some of the work that my colleagues at IFA are doing on the European Child Guarantee Action Plans, where there's a similar picture where we're past the deadline, but there are still action plans that we're waiting for. And I think this points out kind of that there's a lack of political will to act on such issues. So a similar thing can also be noticed on policies in healthcare access and health. Now, at any rate, this shows obviously that we need to keep in mind the topic of intersectionality and the social determinants of health. And then I sort of refer more to like topics such as disability, ethnicity, age, or because these influence women's health status sometimes doubly, of course. So one strategy in this case is not enough. We need a holistic approach that addresses not just the gender dimension, but also these other dimensions that I just mentioned. Now, the EU supports this kind of approach through its European Pillar of Social Rights, but I think it's important to point out that most action still takes place on the national level. The EU supports, obviously, member states, but they can point out that it's not just a health issue, but it's also a human rights or social determinants issue. But still, most of the action takes place on the national level, and that's why I also to a conclusion now, and I will try to briefly point out sort of three main points that I think are important to focus on the national level. So, as I said, gender inequalities in healthcare are quite a complex issue, and we cannot, issue simple recommendations to solve such. Added to that fact is that the healthcare system in Europe, for the most part, is a national responsibility. It means that the European Union has very limited influence. It can give recommendations, but it cannot force member states to take action. member state level, the first thing that I'd like to point out is member states need to focus on a holistic approach. They need to implement action plans which not only account for the gender dimension in health, but also intersectionality and determinants of health, such as ethnicity, as I mentioned before. That's one thing. A second thing is member states must facilitate acquiring disaggregated data, because this is necessary to foster evidence-based policy. As I said, if issues are not known, it becomes very difficult to tailor policy to improve healthcare systems and address women's health needs and prepare for any kind of health crisis or a crisis of a different form. And the third and last point is member states need to take lessons from crises, such as the pandemic in Ukraine, to see what issues women face in healthcare, and then design policy based on those lessons to address these issues structurally and prepare for any kind of future crisis. With that, I'd like to thank you very much for your attention, and I will pass the floor back to Darko.
Thank you, Thomas. I will go briefly in through some of your points. The first one was the lack of gender health disaggregated data, and also disaggregated data that can foster evidence-based approach and equal actions. Also, women's participation in policy development and decision making is one of the problems across Europe and also in globally. Lack of plans to improve women and child care policies, lack of political will, and lack of holistic approach addressing different issues. On national level, your recommendation was to focus on developing action plans that will include holistic approaches and will be based on holistic approaches. Countries to work on disaggregation of data on different, including gender aspects and other ethnicity aspects and so on. And also to focus their future policies and current policies on lessons learned from the current and also past crisis. Thank you very much, Thomas. I would like to invite our next speaker, Nilanjana Das from SAMA.
Thank you, Darko. Hello, everyone. My name is Nilanjana, and I will be representing SAMA and PHN Gender Justice Group today. So before I begin, I would like to just mention that whatever recommendations or pointers that I will be putting forward will be based on my experiences with frontline health workers and women whom I have interviewed during my course of research and program implementation over the last past 2 years. So just let me know if you could see my screen.
Good.
Yes.
Yeah. So a lot has already been talked about how COVID-19 has altered the lived realities of women, especially across the globe. And I think Renu also talked about how it happened in India. So this is just a glimpse of what was going on. So we know that COVID-19 heightened inequalities and especially the rerouting of healthcare services from government health facilities was a critical factor in denial of services. And women, especially from rural and tribal areas, had to face a lot of issues. We heard about several instances where women were denied care and they had to even give birth in extremely difficult situation. This is one case study from the tribal state of Chhattisgarh, where we interviewed one woman who went to labor during the middle of the night, and she turned out to be COVID positive, and the healthcare workers completely refused to even touch her, and she was asked to deliver in the parking area. And it was December and very cold, and she kept on pleading the healthcare workers to help her, but none came forward because there was a huge stigma attached at that time. So later on only she had to give her delivery on the floor in the parking area, and after which they sent her to an isolation facility. And this is just a few case studies that have been happening and have been coming up even in media. So there has been several instances of sexual violence and harassment, even when women were trying to access COVID care in quarantine centers. And we have to understand what kind of influences women's perceptions in order to understand how we can make the access better for them. So we spoke to several women, and there were issues of access to transport, especially for rural and tribal areas where women were dependent mostly on public healthcare services, and they did not have their own means of transport. And we have to understand that the reallocation of resources was very critical in leading to the denial of care. So in most of the rural and tribal areas, women actually prefer the community health worker, who is also known as ASHA in India. And they would first approach the primary healthcare center or health and wellness center, which has now a much more broader focus apart from sexual and reproductive healthcare services. So in case that is not available, then next immediate point of contact would be always the rural medical practitioner, who is a unqualified private practitioner, but providing healthcare services at very cheap rates. And they're usually called in colloquial terms Jhola Chap doctors, and they're available at their beck and call. They would also come at night time at your own house. And that is one of the reasons why women often rely on the Jhola Chap doctors, because of the convenience that is there. So issues like distance to health center, timing of the healthcare workers, and access to transport are critical factors. We have seen that where primary healthcare centers, or now that health and wellness centers, who have drugs and ANMs or medical health professionals stationed there throughout, has a huge difference in the uptake of services in those areas. One of the recommendations would definitely be strengthening the health and wellness centers, because this is not just serving the needs of women of a particular age, but also aging women. So health and wellness centers are also catering to the needs of hypertensive and diabetic people. And we have seen that aging women as well are wanting to use health and wellness centers if there are medicines available, because it reduces their out-of-pocket expenditure drastically. Expanding human resources in health systems has been a critical issue for several years now. And this is just a snapshot of the state of Chhattisgarh, where largely our work has been based. So as you can see, in the peripheral areas, which are mostly tribal dominated, the vacancy rates are much higher as compared to the central areas. The Raipur being the capital of it has like 0% vacancy. And this is not something new, but what we did realize that in extremely remote and tribal areas, especially where the particularly vulnerable tribal groups were situated, who are completely cut off from the main settlements and are even more impoverished than the normal Adivasi communities, if there is an ANM stationed in a mini health center, the people definitely prefer to go to the ANM, and the uptake of services is very high in those centers. There have been quite a few notable initiatives over the years, and recently in health and wellness centers, which has been the part of the Ayushman Bharat, we have seen that the enrollment of community health services, which is a mid-level healthcare provider, has really helped in tackling the problem of human resources to some extent. We have seen that there are initiatives like Chhattisgarh Rural Medical Corps and the 3-year program Rural Medical Assistance, who have helped in bridging the gap in the HR, especially in remote tribal and rural areas. There has been a deficit in the trust among people towards public health systems. And this came about when we were working on equitable access to COVID-19 vaccines, and people were very hesitant because they believed that there might be, poison mixed in the vaccine, or they might be trying to take out your kidney when you go for your vaccination. And there were instances where there have been deaths which took place in those villages, but there was not much clarity given to them by the healthcare systems or the healthcare workers about what caused that, which kind of led to more rumors and misconceptions percolating in the community. So one of the ways that we saw that this vaccine hesitancy and the effective public health communication could happen was through the contribution of ASHAs and as part of the healthcare team, and they were positioned very uniquely. And while once the ASHAs went about and spoke with women, especially, there was a huge difference. And we had also conducted, as part of summer community health workshops, to upskill the grassroots health workers about the myths and conceptions of COVID-19 vaccines. And we saw that when grassroots healthcare workers, ASHAs, went about and talked with women, talked with the community members directly, that kind of really changed a lot of things. There's this one video which I probably share about a Bega woman, Adivasi woman from PVTG group, sharing her own experience as a lactating mother, how she has taken the vaccination. And when we kind of circulated that video among our groups, I saw that there was a lot of positive response from the community as well about towards the vaccination. So we also saw that while ASHAs were doing a lot for the community, and they were at the forefront even at the onset of the pandemic, and even during the rollout, there was a lot of issues with their own vaccination process which lacked transparency, and they didn't have support system in case there were some AFI adverse events. So the ASHAs were also forced to take the vaccination before anyone else, or else they were threatened with certain coercive measures. And this is important to understand, that a woman who is also a bridge between the community and the health systems is going a long way to provide healthcare services, should not be belittled or should not be feeling insecure while providing these services, and their demands have to be also acknowledged. One of the important difference that we saw was that if the frontline worker was from the local community, they felt much more accountable towards the community, and there was also more continuity of the services, since they were not traveling long distance and they were placed in, let's say, in that remote area, so they didn't have to actually worry about trekking 5 kilometers uphill or going in very bad roads. Another thing that we were very pleasantly surprised was that the women's collective, which are known as Mahila Arogya Samiti in like urban areas, they played a huge role during the initial phase of lockdown, when there were a lot of community members who were struggling with food insecurity and access to healthcare services. And these women came together and they were able to work with the ASHAs and with the help of other local government officers, they were able to get a lot of things moving. Definitely, there has to be an increased government expenditure on health. And as we see that despite COVID being a pandemic which has hit at the global level and the kind of impact it had on India, we see that the increase in the expenditure is very negligible. In fact, there is a decline if you consider inflation, and even policies which directly impact women, such as like one-stop centers which cater to gender-based violence survivors or other nutrition schemes, they have seen very marginal increase. In the end, I would just also like to conclude that as part of the civil society or our health movement, it is important to advocate these issues. Whatever we see on the ground, we need to flag it. And during the initial phase, when there was a denial of healthcare services happening, Sama had filed a PIL seeking that access to healthcare, sexual and reproductive healthcare services has to be restored. And there has been also attempts to build capacities of CSO members, and like other people have also highlighted, research and evidence-based advocacy has to be done with policymakers. Thank you.
Sorry, I was not unmuted. Thank you, Nilanjina. This was the whole presentation was really inspiring and had very good points. I would emphasize some of them. The first one is the very important is the impact on non-COVID health services, or different or the impact of the pandemic on other services in the area of health. Reallocation of resources or budget and policies are not, I put sunflowers, and cannot follow the ongoing challenges. Lack of health and trained staff. Trust in community-based centers is high among community members. Addressing the needs of isolated areas is very important. Building trust in public health systems among patients and among citizens. ASHAs, community health workers or patronage nurses and their role should be emphasized in order to provide direct support and to the communities and change the reality. Especially, it's very important those staff to come from the local communities and have the knowledge about their lives and about their habits. Needs of health workers, especially nurses and community workers, have to be addressed adequately by the government, connecting communities and professionals, and connecting communities among themselves in order to support and their actions, and also exchange their knowledge. Increase expenditures based on citizens' needs, and also expenditures planned and implemented based of following the economic indicators. And the last one was the civil society organization active role in advocacy, especially evidence-based advocacy in front of the institutions. Thank you, Nilanjina. We have one more presentation from my colleague Borjan. Borjan.
Yeah, thank you, Darko. Really, a lot was said by previous speakers. Very, very concrete and very good points and recommendations. I will just back them up and not repeat them. I will just focus on several few issues. The primary role of the CSOs, let's start from the CSOs, is to continuously work with marginalized communities and marginalized women, and continuously empower them and enabling them to demand accountability from the authorities for delivery of the proper healthcare services, even outside of any crisis. And also to demand from the authorities to listen to the voices and include the vulnerable communities and vulnerable women in the decision-making processes. In order to hear the barriers which they face in access to health care and other services, and to timely and properly address them to a holistic approach, which was mentioned. But also the authorities to learn from the marginalized groups. What were the obstacles which they faced in this crisis of the pandemic or the war, in order for them to be, to authorities to be prepared when if some new crisis emerge, the measures measures which are adopted by the authorities to be in accordance with the specific needs of the vulnerable groups. So let us learn lessons from this crisis and not just returning back to some so-called old normal. also, it's very important to work on the local level with local authorities and with governments in order to establish coalitions and interactions on local level among all relevant local stakeholders, local authorities, health providers, representatives from marginalized groups, to work together to create plans how to cope with in crisis and emergency in order to address the very specific needs, because we have seen in this pandemic that measures adopted by the central government on a high level does not tackle the needs of the people on the local level, and especially marginalized groups. So this asset should be built on every local level, so no one to be left behind, and everyone needs to be taken into account. And also, each community should identify their own assets. They don't just have problems, they also have assets. And this should be identified, which assets could help in the time of crisis and emergencies. One very valuable assets which was shown during the pandemic are the local CSOs. Local CSOs in many cases were the first respondents in the marginalized communities in the pandemic. And they were first respondents, and in many cases only respondents in the vulnerable communities. So, but for example, in North Macedonia, the CSOs were never recognized as a first respondents, first line workers as a response in the crisis. So they didn't benefit anything from the state. So this should be taken account by the states and by the authorities to recognize the CSOs as a first line respondents in any type of crisis and emergency, and to be not just recognized, but also supported and backed up by the state, either national level or local level authorities. And again, intersectionality was mentioned many times. And again, all authorities, CSOs, and communities should really work much stronger in order to diminish the stigma, the prejudice, and discrimination towards the marginalized groups, especially women, to work also not just among the providers, but also among the communities themselves in order to diminish these negative practices. Thank you very much.
Thank you, Borjan. You had very good points. You were talking about the vertical relations among government, CSOs, and citizens, especially marginalized groups, and you were emphasizing the need of joint collaboration and bottom up and up to bottom collaboration and support among all the actors, and especially you emphasize the need of recognizing and supporting civil society organizations as a frontiers or the first line in each crisis. Thank you very much. Thank you all speakers in the second panel, and thank you all speakers from the first panel. I will invite the rest of the participants to share their experience, their thoughts, ask some questions, and also give some suggestions on the topics that we have discussed. Okay, if we don't have questions or suggestions, we can finish the webinar. Thank you all. We will share the presentations and also the video with all of you. Thank you very much again, and hope to see you all soon.
Thank you.
Thank you.
Bye bye.
Bye.
Thank you all.
Thank you so much.
Thank you, everyone.
Thank you. Bye bye.
Thank you. Thanks a lot. Bye.